Physiologic anemia of infancy. At birth, normal full-term infants have a high level of hemoglobin and larger red blood cells than do older children and adults. However, after 1 week of life, there is progressive decline in hemoglobin level that persists for 6 to 8 weeks. The resulting anemia is referred to as the physiologic anemia of infancy. With the onset of respiration at birth, more oxygen becomes available for binding with hemoglobin, and the oxygen hemoglobin saturation increases from 50% to more than 95% or more. There is also a gradual replacement of fetal hemoglobin to adult hemoglobin after birth, which results to replacement of the high oxygen affinity fetal hemoglobin with a low affinity adult hemoglobin. Increase in blood oxygen content and delivery leads to a downregulation of erythropoietin, which leads to a suppression of erythropoiesis. With no erythropoiesis, aged RBCs are removed from the circulation with no replacements, which leads to a decline in the HB levels. This continues until the oxygen demand becomes higher than the oxygen delivery to the tissues. This point is reached between 8 and 12 weeks of age when the hemoglobin concentration level is around 11 grams per deciliter. At this point, erythropoietin production increases and erythropoiesis begins. This anemia should be viewed as a physiologic adaptation to extrauterine life, reflecting the excess oxygen delivery versus the tissue oxygen requirements. There is no hematologic problem and therefore no therapy is required unless the physiologic anemia of infancy is exacerbated by other ongoing processes. Premature infants also develop physiologic anemia known as physiologic anemia of prematurity. The HB decline is more extreme and rapid, with HB levels reaching 7 to 9 grams per deciliter within 3 to 6 weeks of age, and even lower to very small premature infants. In premature infants, physiologic hemoglobin decline is intensified by blood loss from repeated phlebotomies to monitor ill neonates. You see, premature infants have a shortened RBC lifespan, which ranges between 40 to 60 days. And there is a rapid increase in the red blood cell sizes. All of this will increase the demand for erythropoiesis. Even with all that, the plasma erythropoietin levels are still low, below the threshold, and this leads to an even suboptimal level of response to the degree of the anemia. This is because the erythropoietin synthesis is handled by the liver during fetal life, and the liver's oxygen sensors are insensitive to hypoxia as compared to that of the kidney. The developmental switch of the liver to kidney erythropoietin production is not accelerated by early birth, and therefore the preterm infant will have to rely on the liver as the primary synthesis of erythropoietin, which leads to a diminished response to anemia. Due to the pronounced decline in hemoglobin levels and the abnormal clinical symptoms, the anemia of prematurity is not considered benign, and transfusion is required when there is symptoms. Treatment. As I said earlier, physiologic anemia of infancy does not require any treatment. In the full-term infant, physiologic anemia of infancy requires no therapy other than ensuring that the infant acquires the dietary nutrients. For the preterm infants, transfusion may be required to increase the HB to levels that are considered safe to the child. And when transfusions are necessary, an RBC volume of 10 to 15 ml is required. Delayed cord clamping or umbilical cord milking at birth results in fewer transfusions and reduced intraventricular hemorrhages and necrotizing enterocolitis in preterm infants. Because premature infants have been known to have a low level of erythropoietin, the human recombinant erythropoietin is an alternative to transfusion for infants with symptomatic anemia of prematurity. Iron supplementation is given together with erythropoietin for optimized effect. Iron therapy is indicated for all infants with anemia of prematurity, starting at 1 month of age up to 1 year, with a starting dose of 1 to 2 milligrams per kg per day of elemental iron. That's all. Bye.